Okay, Chapter 4. This is going to be your last chapter for Unit 1 for Module 1. So this will be the very end of your content for your first test. All right, so, we talk a lot in the beginning about prenatal care. It's so vitally important. I could tell you 100 stories of people that have come in with horrible outcomes because they didn't get prenatal care. Some people are like, I don't need prenatal care. Women have been having babies for thousands of years. And that's true, but we still have to remember that our mortality rate is much lower than it was even 50 years ago. So as a nurse, you are going to be an educator for the rest of your life, and that's part of prenatal care. The biggest thing I can stress, and it will be on your test, is that parents that get prenatal care and attend childbirth classes, those women are more in control when they go into labor because they have a base of education. They have a knowledge base on what's happening with their body. And so it's really important that people do get good prenatal care. A lot of times we could have prevented horrible outcomes if we had discovered a situation early, such as like anemias or diabetes, gestational diabetes, those sorts of things. So our primary goal is, of course, we want mom to have a safe birth and a happy, healthy baby. And to do that, we are going to be promoting good health habits. And by doing that, we're going to be reducing their risk factors. So we're always teaching about healthy habits. I don't care if you work in labor and delivery or in a doctor's office or go to work in a cardiology floor. I mean, everything we do is about teaching healthy habits to our patients. We need to educate them on how to take care of themselves when they're pregnant, and provide physical care, of course, to them. And then we're just also preparing the parents for the responsibilities of parenthood. Let me stretch this just a second so you can see the rest of this screen. Sorry. This is always fun when your teacher has to do this, right? Okay, prenatal visits. So care should begin pretty much when she suspects that she might be pregnant. Actually, care should begin before that. Hopefully people are preparing themselves to become parents well before the pregnancy actually happens. But there are a lot of considerations. I mean, I'm sure we all have friends that they were not expecting to get pregnant and they're having a baby. So those things do happen. But the moms that are getting the care before they go in for fertility counseling with their OB-GYN, and they find out what vitamins they should be taking, what their optimum weight range should be, how much weight can they expect to gain. They can look at make sure that there's no abnormalities with the uterus or the fallopian tubes or the ovaries. Those are the things that we hope, that would be nice if everybody could do that. I know that it's not possible, but so what happens after, the stick turns blue or whatever, or tells you that, you've got a positive pregnancy? Well, you're going to call your OB-GYN, and they're going to want to see you right around week 8. So at that first visit, you can count on them getting a thorough health and physical. So our history and physical, they're going to ask all kinds of questions about your family history, his family history. Are there any defects in the family, or are there any chromosomal defects that we need to know about? Those sorts of things. Nationality can play a big role. There are some diseases that are like thalassemia is very common more in the Greek culture than it is anywhere else. So there's other things, and we will get into those toward the end of the 8 weeks here. They're also going to draw a bunch of blood. This is what they're going to get. They're going to get a CBC, hepatitis B, HIV, rubella, BDRL. They're going to check your starting blood glucose. They will probably draw what's called an MSAFP. That's maternal serum alpha fetal protein. And that is just a marker that can tell us if you're at risk for Downs or for a chromosomal defect. It's not the definitive diagnosis. The only way you can get those diagnoses is through an amniocentesis. The VDRL is for syphilis. They'll also do a pap smear and make sure that there's no cervical cancer, and also they'll get cultures for gonorrhea and chlamydia during that pap. Urine culture, you're going to give urine every time you go in. They're going to dip it. They're going to be looking for protein glucose leukocytes. A lot of women are most women are prone to getting bladder infections, UTIs, while they're pregnant because the pH in our body changes and it makes it a more favorable environment for those bacteria to grow. But often when you're pregnant, you don't feel like it doesn't burn when you urinate. There may not even be blood in the toilet. So that's why they check every single time, just to make sure that mom's not getting a UTI. So, how often will they be seeing the doctor? You can let them know in their first visit. We're going to see you once a month. So once every 4 weeks for the first 28 weeks. And then, so that's for the first 7 months. And then for the next, from 29 to 36, so for the next 7 weeks, we're going to see you every 2 to 3 weeks. Usually it's every 2 weeks until they get to 37 weeks, and then they see them weekly after that, just so they can keep a close eye on and make sure that they're not dilating prematurely or if we're getting ready to go into labor. Also, they'll get vital signs, they'll get weight, fetal heart rate. If the baby is big enough, they'll try to do Leopold's, but at 8 weeks, it's not going to be. They're going to get at that visit, they'll get an ultrasound, a vaginal ultrasound, and they'll be looking for those structures like a fetal pole or the yolk sac that we talked about in the previous chapter. And that can kind of give them a good estimate of how many weeks along they are. We'd like to get those really early so that we can get a more accurate estimated due date, especially if somebody's got irregular periods. Fundal height, they're going to do that. I included a video of that for y'all so that you can see. The big thing on fundal height that I want you to remember is that at 20 weeks, so halfway through the pregnancy, the top of that uterus, the fundus of the uterus, is going to be even with the belly button, with the umbilicus. So just keep that in mind. You've also, I told you that they're going to dip for protein and glucose, and just talk to her about any discomforts, problems, review nutrition with them, that sort of thing. So here's some definitions. Here's our Gravida, that GTPAL thing that I made y'all do. So Gravida is just the number of pregnancies. I'm not going to go heavy into this because I think all of y'all really got it. But parity is the number of pregnancies that ended at or after age of viability. Some call it 20 weeks. I've had other doctors argue with me about that. But if for any reason they had a baby that was after 20 weeks, I would go ahead and count that in the P's. A nullipara is somebody who's never delivered a baby and then a primipara is delivering her first child. So mom could be like a G2, P0. You don't count that until that P is not counted until that baby is born. But after mom delivers, then say she had an abortion or a miscarriage, then, on that first pregnancy, and then now she's got this viable one. So that would make her a G2P1. Multiparas are anybody that's delivered 2 or more children. And this is just a description of what all these little abbreviations mean. Nagel's rule, we talked about that. Y'all have all done really well with that. So you just ask them, what was the first day of your last period? You're going to count backwards 3 months, add 7 days, and then correct for the year if you need to, if their conception took place after March. So diagnosing pregnancies, presumptive signs of pregnancy, missed period, nausea, vomiting, breast changes, pigmentation changes, frequency and urgency to urinate, fatigue and drowsiness, and then quickening. Quickening is those first fetal flutters that people feel, those first little baby movements. Now, these are considered presumptive because they could also be the flu. They may have gas. That's why they're feeling that quickening kind of feeling, those sorts of things. And then pigmentation change, that changes whenever any of our hormones change. Our skin color and texture and stuff can change too. Probable signs, those Goodell signs, Chadwick sign, the abdomen, the uterus enlarges, but that's not definitive, because they could have uterine cancer, they could have fibroids that makes that uterus larger. Braxton Hicks are practice contractions. Ballottement is that you can move the mass around. So if you can palpate a fetal outline, stretch marks on the belly, you can kind of see this picture right below that lady right down close to her hands. She's got some stretch marks. And then a positive pregnancy test. The only positive way to say that somebody is pregnant is with a fetal heart rate, with fetal heartbeat. So Doppler, 10 weeks, fetoscope, which nobody hardly ever uses anymore, would be 18 weeks. Fetal movement palpated by the trained examiner, not just mom saying she's feeling the baby move, but you actually lay hands on her belly and you're palpating around and you get a definite kick back. And then, of course, identification by a fetus by ultrasound. So you got to have at least, a fetal heart rate, get an ultrasound, they see the baby in there, or you actually feel fetal movement by the examiner. So normal physiological changes. The endocrine glands, placenta is going to be producing the hormones at this point. So it's once that placenta is in place, then all the progesterone and estrogen, all that stuff is all going to be taken care of. Placenta is going to keep everything balanced. That's why we want those really healthy placentas in the very beginning, that mom's eating well and not smoking and those kinds of things. So the uterus, cervix, ovaries, vagina, breast, all those are going to change. Pretty much everything just gets bigger. Respiratory system, we breathe deeper because we're having to oxygenate somebody else as well as ourselves. Shortness of breath, dyspnea is very possible, especially as that baby gets a little bit bigger and is pushing up. And also around probably somewhere between 12 and 20 weeks, most women have a drop in their H&H, and it's because we've got more body fluid. We gain about a third more body fluid, and so this causes nasal stuffiness. A lot of women, as soon as they lay down, they can't breathe, that sort of thing. They can also end up with nosebleeds, epistaxis, ears. They can get ringing in their ears, that sort of stuff. But back to that dyspnea, because you've got that diluted H&H, because you've got more fluid in your body, but not necessarily more platelets and red blood cells, your body is tricked into thinking that it's anemic, and so that's why we get short of breath also. So frequency or a tendency toward UTIs, it's very common. I told you that because of the pH changing. Cardiovascular system, our heart actually gets displaced a little bit further to the left, especially, as that baby's growing. We're going to have a higher heart rate because we got to pump blood faster because we are filtering for not just us, but for our baby. Orthostatic hypotension is very common, goes back to the anemia thing. You got to stand up too fast, you get very dizzy. GI system, very common to have increased salivation. This is to help us digest our food because everything slows down. So that's where you get this peristalsis. Increased appetite, and increased thirst. Obviously, you're not actually eating for two. You only need 500 extra calories a day while you're pregnant. But a lot of people take advantage of that, and they go to Brahms every day and get a shake or whatever, But that's where that extra weight comes from. So because of the progesterone, all of our organs, kind of like our digestive organs, all slow down. So it takes longer to digest food, which is going to make that food stay in our stomach longer. And so that's where we get this heartburn, because also it's relaxing that pyloric sphincter at the top above the stomach going into the esophagus. So because that's relaxed, it's taking longer for our food to digest when we go to lay down after we've eaten, then it's very possible that we get heartburn very easily. And because everything's slowing down, guess what? Our body's pulling more fluid out, and it tends to make people lean more toward constipation as well. Skin changes and skeletal system. The linea nigra is just a black line of hair that goes from the belly button to the symphysis pubis. Spider nevae, or little spider veins, as we call them, they're usually found like around the knees, the joints on the knees. That's that place. You'll see these little breaks in capillaries. It's not a big deal. It's not life-threatening or anything. The waddling gait, as we get further into our pregnancy, our body starts to release relaxin so that our hips can shift outward and makes it easier for the baby to come through the pelvis. So that's where we get that waddling gait from, because everything's just kind of loose. And that's also why we get a lot of backaches. That and our center of gravity is changed, and we get lordosis, which is the arching of the back, and your center of gravity is more forward, and so it causes that back to arch really bad. And that's where we get those low backaches. And then striae, which is just your normal stretch marks. So weight gain. If somebody is a normal weight and they have a good BMI, then we tell them, well, you can gain 25 to 35 pounds. That's totally normal. 5 pounds is expected during the first trimester, and then 1 pound a week after that. If they're underweight, we may let them gain a little bit more. If they're overweight, of course, a lot less. If they're obese, then they're going to probably recommend them to only gain between 11 and 20 pounds. There is a question on the test, and they ask about the patient comes to the doctor's office and she's got her mother with her, and the mother is like, I just don't think that she's gained enough weight. And you review it, she's got a good BMI and she's gained, and you got to calculate 5 pounds during the first trimester. So that's up to 12 to 14 weeks. She should only gain 5 pounds, and then 1 pound a week after that. And it's going to give you the gestational age, and then you have to calculate how many pounds she should have gained by that point. Nutritional requirements. Big thing is and this is really important to stress to our teens, and there are a couple of teen questions on the test. Sorry, I had to get a drink of water. Protein, we're talking 60 grams a day. Calcium needs to be increased by 50%. They need to eat, hopefully we're getting our calcium from our foods. All of our vitamins should ultimately come from our foods. But if you have a teen, you're probably going to want to just go ahead and put her on a calcium supplement, because they are probably not going to get enough of these. I mean, I don't know a whole lot of teens that love broccoli and green leafy vegetables and canned salmon and sardines and that sort of stuff. So it's always a good idea if you've got a teenager to go ahead and put them on a calcium supplement. You have to remember, too, that whenever a teenager is pregnant, their body is still growing. Their bones are still calcifying. So they should be getting, extra calcium anyway in their diet. And now they're pregnant and they're trying to form another human being. So it's going to pull from mom to give it to the baby. So that's why we need to make sure that they're eating correctly. If they're getting plenty to drink, 8 to 10 glasses per day, that is like a 16-ounce cup, So I would tell you, especially in the summer, I always told my ladies, try to drink 1 gallon a day, because you really need it. You're going to have that existential fluid loss. And so, and I've already told you that their breathing is increased. So they need to make sure that they're getting plenty to drink. Iron supplements are best. Of course, if you're eating green leafy foods and liver and things like that, if that's what you really like when you're pregnant, you're probably getting, quite a bit. But because we do have that tendency toward anemia, we need to make sure that we are getting plenty of iron. And the best way to do that is through a supplement. Folic acid should have been started before pregnancy occurred, but if it doesn't, we need to start it as soon as possible afterward. This is going to prevent those neural tube defects. And then sodium, there's no need to restrict their sodium. Okay, so here we go to special nutrient considerations. Pregnant teenagers, they're going to have peer pressure. They're more prone to fad eating, bulimia, anemias. They don't want to gain a whole lot of weight. They may even be trying to hide their pregnancy. So if they're doing that, they're probably not eating correctly either. And then they've got, of course, they're a disturbed body image. So those are all of your possible, nursing considerations. Sodium intake, forced fluids, which means that, we just need to make sure that they're getting enough to drink as far as water goes. Less soda is more water. Vegetarianism, if they're going to be a vegan or a vegetarian, we need to make sure they're getting plenty of protein-rich foods. I will tell you from experience that vegetarians, they tend to have less, or how does this? Their skin is more friable. So that means that if they deliver vaginally, their tears are much worse. Or if they have to have a C-section, then it takes longer for that incision to heal. Lactose intolerance. If they're lactose intolerant, then you just make sure that they're getting a good calcium supplement. Lactation, once again, only increase the calories by 500 a day and 8 to 10 glasses a day. No caffeine, because the caffeine will make the baby jittery. Continue their prenatal vitamins while they're lactating and breastfeeding. Omit the gas-forming foods like broccolis and beans and things like that, and limit alcohol and caffeine intake, because all of that gets passed through to the baby. Exercise during pregnancy. We're just trying to maintain fitness. We're not trying to make you fit. If you're out of shape and then you get pregnant, you decide you're going to get in shape, too late. You can walk, you can do low impact aerobics, that sort of thing, but we're not going to do a whole lot to try to get you fit and toned while you're pregnant. Excuse me. Anytime our temperature gets elevated, that means there's decreased fetal circulation. So we don't want to do any hot yoga or any of those things. Hypotension from the compression of the vena cava. This is why we make people lay on their left side. So we don't want to do any back exercises like sit-ups or something like that. Our cardiac output changes and may decrease fetal circulation when we're working out, because guess what? Our body's going to try to divert blood to our muscles. And so that's why we don't want you doing, like really heavy workouts. Hormone changes can induce early labor. So if you are working out a whole lot, and it may change your hormones, and you can actually put yourself into labor by working out too much. Other factors, make sure they warm up, cool down, exercise with balanced nutrition, no scuba diving below 30 feet, increased fluids. Talk test. That means if you can talk while you're walking or performing whatever the activity is, you want to be able to continue to talk and hold a conversation. And then you know that you're getting the right amount of exercise. If you can't talk and hold that conversation, then you're probably pushing too hard. Traveling during pregnancy, they can travel by airplane. They need to get approval from their care provider. Everybody who ever rides in a plane, especially for long flights, you are putting yourself at risk for DVTs in your lower extremities. So we tell them, be sure that you get up and you walk around, and just, walk up and down the little aisle there, down to the bathroom, and then come back and wiggle your feet and your toes and stuff like that to keep circulation going. If they're getting really close to term and they really, like if there's a death in the family or something like that, this is a trip they have to take, then we want to make sure that we try to give them their obstetric records to take with them, just in case something happens if they're in another city or another town. And then, of course, we're always telling them to avoid locations with high risk of infections. So like West Nile, there was for a while there, nobody could go to Florida. They were telling pregnant women, don't come to Florida because they had a lot of West Nile. I wouldn't go to some place that was in an outbreak of SARS or something like that if I was pregnant. These are the common discomforts, and they will come in and they will complain of this. On and on and on, and you just have to tell them this is normal. All of this that you see on this slide is normal. Nausea and vomiting is very common in the beginning. We want to tell them to avoid greasy foods. Anything's going to take a long time to digest. A lot of women have an aversion to hamburger meat, but red meat takes longer to digest, so maybe that's why our body does that. Keep some cut toast and crackers beside the bed. Be sure you're drinking plenty between your meals. Smaller meals, more frequent meals. Vaginal discharge does increase. We'll make sure that they're wearing cotton panties, no douching, and just make sure they're staying clean down there. They are also, because of that change in pH, not just prone to UTIs, but they're also prone to, yeast infections. Fatigue is very common, especially in that first trimester. Your body's building another human. It's very tiring. You need a minimum of 8 to 10 hours, but I'll tell you, most pregnant women tell you they could sleep 16 hours straight in the very beginning. Backache, yoga is really good for this. Lots of stretching, posture, and body mechanics. Make sure they're standing up straight, those sorts of things. Constipation, I told you, because our digestive system slows down so much. So we want to force fluids and fiber. They may need to take a Dulcolax every day, exercise, walking, and make sure they're getting plenty of fluids. Varicose veins are often very common because we've got that relaxin and the progesterone and all that is just causing everything to just be really, really relaxed. And so we want to tell them, to prevent varicose veins, no tight clothes, try not to cross your legs, no standing or sitting for long periods of time. And when you can, elevate your legs, get them up, because also this is going to cause swelling in the lower extremities when you're pregnant, and this is why, because of that decreased venous return. Hemorrhoids are very common. We want to avoid constipation, so do all the constipation maneuvers. They can do a sitz bath. That kind of helps with any hemorrhoids that come up. And then they can use Tux or Preparation H or whatever is their choice for an anesthetic ointment. And that kind of helps with those anesthetic ointments. You put that in place before they actually have the bowel movement. It'll help a little bit with them being able to pass their stool. The dyspnea and nasal stuffing is just rest upright. Maybe put an extra pillow beneath your head and do saline spray. Heartburn, if they're smokers, they need to stop or at least decrease as much as they can, and stop or decrease caffeine. They may have to sit or sleep upright. You want to make sure that they're eating, that they're not eating within that 3 to 4 hours before they go to sleep. And if they do, then they need to, start off sleeping, fairly upright. Deep breathing, teach them how to breathe a little bit deeper. Our breaths seem to be a little bit shallower when we're pregnant. Leg cramps and lower extremity edema, elevate those legs, do foot flexing exercises, and avoid restrictive clothing. The psychological impact on the mother. First trimester, this is kind of that, I'm pregnant, and it's not concrete with them. It's like, okay, I know I'm pregnant. Our emotions are up and down because we've had these huge hormone changes. I remember I had a complete meltdown just because my dryer went out. And so don't expect, with the ambivalence, it just means it's like, I'm pregnant, it's not going to change our life. Everything's going to stay the same. Second trimester, we start to kind of get real about it. Our body, we start, showing a little bit, and people are now starting to ask. And so now it's become more reality. And you realize that you've got this separate little human being inside you. And this is when we start wondering what the baby will look like. It's going to look like me. It's going to look like him. And husbands often, and even moms, will worry about sex hurting the baby, which is not true. So third trimester, we start to feel big and ugly and unloved. Our moods are labile again because of another hormone shift that we've had. We start to make our concrete plans about the baby. We start having baby showers, and we start setting up the nursery and those sorts of things. And we start shifting from just pregnancy to what am I going to be like as a mother? Father psychological impacts. So this is when we start doing our psychosocial assessments when we first admit these patients in labor and delivery, or if you're in the doctor's office, you're going to find out all this stuff too. So the father, is the father from the same culture as the mom? If not, those are things they need to talk about, because sometimes in one culture you do one thing with the baby, and then in another culture you'll do something else, and so those things have to be talked about. Whether it's you're Jewish and he's Catholic, or whatever the case may be. And then grandparents, they're so excited, and distance will dictate the degree of involvement. The further away they are, it's harder for them. But now we've got Skype and things like that, so that helps a lot. Conflict is minimized with similar views of parenthood. So if you do decide, I don't want to be anything like my mother was, I'm going to do this completely different than the way I was raised, then you might start butting heads with mom or with your mother-in-law or something. Single moms, we need to really, kind of find out for these poor ladies, who's going to be there to support her? Not financially, but emotionally. Does she have anybody that is going to be supportive of her? Does she make enough money? Does she have everything she needs? I know in Denton, we've had several instances where women have come in to have their baby. They're going to UNT or to TW or wherever, one of the colleges, and they've gotten pregnant and they haven't told their families. And they come in and give birth and give a baby up for adoption. And I'm like, you really need to talk to somebody. There's got to be somebody in your family that you can talk to about this. And I really try to stress that to them. Most of the time they don't, but I'm hoping at some point, they have somebody to talk to. So anyway, back to resources. Do they have all the resources? What are they going to do about daycare? Are they going to go back to work? Where are they going to live? These are the things we need to find out. Do they have water? Do they have a car? Are they going to be able to make it back and forth to doctor's appointments and to the hospital? Do they have somebody, if they've got other children, they have somebody who's going to watch those children for them? Single dads, they may take an active interest, or they may only provide monetary support and think that that's enough. So adolescents, we get into this because not only do we have a single mother and father, now they're very young and they have a variety of emotions because they're already emotional because they're adolescents. And we really, really have to support those young ladies. And, I don't care if they're 14 or, 15, 16, whatever it is, you need to find out, what does their family think about the pregnancy? Are they happy about it, or are they really disappointed? Are they going to be supportive? Are they going to help, with the baby so that mom and dad can continue going to school? Because we need to, get these people to get a higher level of education so that history doesn't continue to repeat itself. And then siblings, make sure that they get their individual time, that they're still getting lots of attention. Because when the baby comes, all of a sudden it's not about them anymore. It's about a baby that's getting mom and dad's attention. So we need to make sure that we're including them in everything. Other important information. Make sure that, we're giving them all the prenatal education that we can. We kind of prepare women when they come to the doctor's office, and we give them, this is what to expect for the next month kind of deal. The effects of pregnancy and lactation on medication ingestion. So we don't want anybody to be taking anything without their doctor's approval. Now, they'll give them a little list of medications in the very beginning that they can take. They can take like Tylenol, Benadryl. Those are the two that come right off the top of my head. Antihistamines, they really need to talk to their physician which one they prefer. Usually I think it's Zyrtec that they let them take. So if they have really bad allergies or something like that. But we always have to keep in mind that every medication we take pretty much goes through our breast milk to our baby. And we have to make sure that those medications are going to be okay for somebody that tiny to take. And then immunizations. Give them all the information up ahead of time about immunizations, why we do them. Immunizations are getting such a bad rap, but now we've got we're getting outbreaks of measles, which we've not had in 50 years. So give them as much educational material that you can so that they can make those educated choices based on evidence-based practice. That's it. That's the end of Module 1.